much. So I do have one disclosure. Sorry, it's not there. There we go. I do have one disclosure with regards to this talk, and that parallel grafts are not my treatment of choice as a first-line therapy for complex aortic aneurysms, but I do think that they have a role in the armamentarium of the vascular surgeon, and we'll discuss why. So parallel grafting, in terms of definition, it's an umbrella term that covers what's been called snorkels, chimneys, periscopes, or sandwich grafts, and it sort of encompasses them all. And basically what it is you have a stent graft that goes outside of your tube graft into essential branches of off of the aorta. And the idea is that rather than you'll get a seal between the two devices if you can get adequate coverage. The alternatives to parallel grafting, your traditional open repair, there are off-the-shelf branch devices, such as the T-branch made by Cook and the Tambi made by Gore. There are custom branch or fenestrated devices, which we use at our institution. In the United States, what's been popularized is, in a number of centers, are physician-modified endografts, and so they actually manufacture their own fenestrations, or aortic debranching. And I think each of these may have a role. But the benefit of parallel grafts is that you can use off-the-shelf devices. So you take devices that are approved, thoracic EVAR devices or endovascular grafts for the infrarenal aorta, as well as covered stents, and you don't have to modify them, and so it's available for emergent cases. You don't need a custom device. There are certain concerns with parallel grafting. There's probably more manipulation in the arch associated with each of these. There are significant device costs because you're using multiple devices, and the main concern is the risk of gutter leaks. And so if the branches and the aorta don't oppose fully, there is a potential risk for perfusion of the sac and continued rupture risk. So I do want to highlight one technique which I think has been popularized by Dr. Minion from the University of Kentucky that really has changed my thinking about the branch grafts, and this is what's called the eye of the tiger technique. And he's been doing it since about 2010, and he reported in this article in 2012. This is a little bit better illustration of it. So what he used balloon expandable stents for the gutters, and he'll deploy it outside the main device, over dilate it, and then leave a smaller balloon inside of it and crush it with an aortic balloon, and then re-dilate it, so you basically get an ellipse. And so this is a technique to eliminate the gutters and get good apposition, and he's a real champion of this. Got just a case that we did where we used this technique. This is a 60-year-old woman who we got a call from across the street at Memorial Sloan Kettering. She'd recovering from surgery for a malignant small bowel obstruction, and they had a fresh small bowel resection and anastomosis. This is her scan before her surgery, and you'll notice that there's maybe some irregularity near the aorta at the paravisceral segment. This was about 2 weeks before we got called. They got a follow-up CT scan for imaging her cancer, and they found a new paravisceral aortic aneurysm at that area where the hematoma was. And she's also got recurrent hypertension requiring IV antihypertensives. And so you can see here, this is within 2 weeks, she's got this pseudoaneurysm at the paravisceral segment, most likely coming off of either the aorta or the origin of the right renal artery. And it's, so this is based off the 3D reconstruction. There's normal aorta above, normal aorta below, and then this pseudoaneurysm paravisceral segment. There's a celiac stenosis, which we know about. There's probably some right renal artery compression by the pseudoaneurysm, which may be the cause of her new hypertension. And so our plan with this patient, we didn't want to do an open repair in the setting of her recent cancer, her metastatic disease, and her recent surgery. And so we planned to do a parallel graft with four vessel snorkels. And so 2 coming from above and 2 coming from below, and a tube vessel in the aorta. This is just to illustrate the pseudoaneurysm just at the origin of the right renal. It was in the OR probably larger than it appeared to be on the CAT scan, so it progressed in 2 days. So we did 2 VBX stent grafts from above and 2 conventional Viben stent grafts from below for the renals, and an Endologix tube graft device, and we'll go through this quickly in the interest of time. And so when we did our completion run, you see the branches, but you see a brisk filling of the pseudoaneurysm still. We had not done the eye of the tiger maneuver. But we post-dilated the visceral segments to 12, collapsed them, and brought them back up to 8, and that was enough to ablate to get rid of the the channel to get rid of the gutter leak. And she had a follow-up CT scan within a few days because of the rupture. And we can see, if you see on the scan, that the gutter leak is clearly eliminated. So I think in cases like this, where it's sort of urgent indication, you don't have time for a custom device, and you don't want to subject them to an open repair, this is a good technique. This is just the 3D reconstruction afterwards. Just in terms of data, I'll go through this quickly. This is from the Pericles registry. They looked at all chimney grafts. In this registry, they found that there was about an 8% rate of type 1 endoleaks. Initially diagnosed, they did intraoperative maneuvers and brought that rate down to about 3%. So 3% had persistent type 1 endoleaks, so technical success rate of 97%. And their survival was about 80% at last follow-up, and the patency for these branches were 94% at 1 year, and secondary patency was 95%. But this doesn't really talk about comparing it to other therapies. This is probably the best real-world experience. This is from the Vascular Quality Initiative in the United States, looking at all complex abdominal aortic aneurysms in the Vascular Quality Initiative. And so they're commercially available fenestrated devices, the parallel grafts, and physician-modified endografts. Of note, this does not include investigational devices or clinical trial devices. And so our own IDE is not included in this. The Aortic Consortium, which Dr. Schneider presented recently, is not in the VQI. And so they had almost the overwhelming majority were elective, 94%, 4.5% were for symptomatic aneurysms. The majority of the cases, 60% were FEVAR, 18% were physician modified, and 20% were parallel grafts. I just need maybe another 30 seconds. So what they found was that the physician-modified endografts were used in patients with more extensive aneurysms. They were more likely to incorporate the celiac and the superior mesenteric artery than patients with chimney grafts. They did find that the chimney grafts required more arm or neck access than the fenestrated or physician-modified endografts. The procedures took a little bit longer, and they tend to use more contrast. And so when they looked at outcomes and they looked between the two groups, they did find a significant difference in the rate of stroke. The rate of stroke was higher in the chimney grafts than physician-modified grafts, and the rate of MI. So 7 versus 0.5 for stroke, and 19 versus 0.1, 19 versus 0.8 for MI. And the combined endpoint of MACE was as well. It was higher than in the chimney grafts. The overall survival was similar. So in conclusion, I would say that this is an off-the-shelf solution for complex aneurysms. I would see its role in urgent or emergent cases when you don't have access to a branch device, and it's a choice between physician-modified or open. The durability still needs to be evaluated critically, but again, it's an important part of your armamentarium to treat complex aneurysms. Okay. Thank you very much.